All right, good morning, everyone. This is Phil Pugh. Welcome to our quarterly coalition meeting. I'd like to thank everybody for joining. Looks like we got about 32 folks on the line, and I'm sure we'll probably garner a few more as we go on. As just an administrative reminder, please keep your phone on mute when you're not talking, and please don't push the hold button, so we don't have a bunch of whether it's Kenny G or Yanni playing in the background. Elevator music is great, but sometimes it's overbearing when folks are speaking. So also, as a reminder, this meeting is being recorded, so it will be uploaded this afternoon on our YouTube page. So if you have missed it, or if you want to send it to somebody who has not or is not part of a coalition, they want to hear what's going on, you can always shoot them a link from our coalition YouTube page. So if you do not wish to be recorded, please log off now and take a listen afterwards. Today's meeting, while it is our quarterly, shouldn't go awfully too long. A quick reminder about IMATS. If you don't have an account and you're a hospital, you need to have an account. Make sure you log in and all your SAMS.gov information is accurate. We'll go ahead and conduct our roll call, starting with our hospitals. We'll start with Anderson Hospital.
Eric's here, and also here for Community Hospital Staunton.
Thank you, Eric. Over to Alton Memorial.
Good morning, it's Aaron.
Gotcha, Aaron. And for Boyd, I know Nancy Wallenweber is on. Thank you and welcome back, Nancy. Carlinville Area Hospital. How about, we already got Eric for Staunton. Fayette County Hospital.
Good morning, this is Tina.
Good morning, Tina. Gateway.
Hi, Danielle's on.
Hey,
Gotcha.
Phil's Rick.
Gotcha, Danielle and Rick. Thank you so much for joining. HSHS Holy Family.
Good morning, this is Kelly Klutz sitting in for Cindy Crouch today.
Thank you, Kelly. St. E's.
It's here.
I'm sorry, was that Brad? It got cut off.
Brad's here, yes.
Gotcha, Brad. Thank you very much. How about Breeze?
Good morning, this is Margie Berry for Breeze.
Gotcha. Thank you. And how about Highland? All right, Jersey Community. Okay, for Memorial Hospital Belleville, you got myself, Lee French. I don't know. I didn't get a chance to see if Scott was attending today. Let's take a look. I don't see him in there. Scott, if you are on, holler out. Eric Perham is off-site presently. He will be joining us later. And Mike Gilbert is here. Memorial Hospital Chester.
Hi, Phil, this is Georgia.
Gotcha, Georgia. Good morning. OSF St. Anthony's.
Gary's here.
Gotcha, Gary. Thank you. How about Redbud?
This is Tara. Redbud's here.
Thank you, Tara. How about Sparta?
Hey, Phil, you got Dan down here at Sparta.
Gotcha, Dan. Thank you. Touche. Anyone from Touche? Nope. We'll move over to our health departments. Bond County.
Terry here.
Gotcha, Terry. Calhoun County. Clinton County. Eastside Health District. How about Fayette? Greene County. Jersey.
Jersey's here.
Who was that speaking? I'm sorry.
This is Heidi Carter.
Oh, gotcha, Heidi. Thank you. Macoupin County.
Derek here, Phil.
Gotcha, Derek. Thank you. Madison.
Michelle's here.
Gotcha, Michelle. Monroe County.
Vicki here.
Gotcha, Vicky. Randolph County. and St. Clair County.
Deborah's from Randolph County. She put it in chat.
Okay, gotcha. Thank you, Chuck.
And Kara's here with St. Clair.
Thank you so much, Kara. Our
Kimber
community.
here with Fayette. Sorry,
I'm sorry, who was that?
Kimber with Fayette.
Okay, thank you. All right, our community partners, starting with Greg Atterbury for our RMSC. Greg, are you on?
I'm on.
Gotcha, sir. Thank you.
Beth is not on. She has a meeting,
Okay,
another meeting.
all right. Thank you. Any of our BJC partners on today? Any emergency management agency staff on?
Jill, this is Sam. I'm here for St. Clair County.
Gotcha, Sam. Thank you.
Mhm.
Any other emergency management agency folks? How about our good folks over at MedStar Ambulance?
Chuck's on. I'm not sure if John was going to make it.
I'm checking the list right now. I don't see his name or phone number. So, okay. But thank you, Chuck. How about Abbott? The folks from Abbott. I'm looking to see if I see Leslie on today. I don't see her. Okay. How about SLU? You know, folks at SLU. How about Scott Air Force Base Partners? And STARS. Anyone who was not able to sound off or call off, please make yourself known now or put it in the chat.
Yeah, James Kelly from Coronaville Hospital.
Gotcha, James. Thank you.
Kim Lambert, Columbia EMS.
Thank you.
Jeremy Gotch, Hammer Muscooty EMS.
Thanks, Jeremy.
A little late, sir, but John Nowak made it.
We got you, John. Thanks. I was scouring you earlier. I know you weren't on at the time, but Chuck said he was covering, so appreciate it. All right. If you aren't able to sign off, you can go ahead and put in the chat and we'll capture it there. All right. Our standard agenda, I think the standout stuff we'll be talking about today will probably be grant status updates and the 2022 plans review and burn/radiation surge tabletop exercise. So we'll go ahead and get started with IDPH. Greg.
Hey, everyone. So I know I've already announced this on our monthly meeting, but there may be some people on here who haven't been on that. But Ashley Taylor, Chief of EMS, has taken a new position. She will now be the Deputy Chief Operating Officer for IDPH. She will remain Chief of EMS until her replacement is hired. I don't have a time frame on that, but my belief would be that it should be pretty soon because doing two jobs is rather difficult. From an HPP standpoint, I don't really want to go into much because I'm sure Phil's going to cover it. But we know the NOFO came out. I know the review of deliverables have gone through IDPH employees to give comment. I don't know whether they've gone out to Phil yet, but he can cover that. I don't have any word on the no cost extension. Beth is not on the call because she is in a meeting for our NASCAR Cup Series championship, which could bring 60 to 70,000 people into the area. Just so everybody, I'm sure you've all heard about it, but is aware of that. That's where she's at today from a public health standpoint. EMS has already created plans, and I know the communication plans for that have also been completed. And of course, that will take place this weekend. I think activities may be starting today, but the big days will be Friday, Saturday, and Sunday. From Beth's standpoint, public health, I don't know if St. Clair wants to jump in. Mila gave an update on COVID for us in the region. Was St. Clair on that call that they want to say that, to give that update? I don't want to step on toes.
Sure, Greg. This is Kara. We just mentioned that St. Clair County has moved into the medium community level based on the new CDC community levels that use not only our COVID numbers, but also hospital admissions and the percent of inpatient beds. There's 15 counties up north that have moved into the high level, and we typically are about 2 weeks behind them. So within the next couple weeks to a month, we sadly are expecting to be in that same position. So that's where we are with COVID.
And that's all I have, Phil.
Thanks, Greg. And yes, I'll be covering some of those grant items a little bit later. Some of you probably seen some of the slides there. And thanks, Kara, for that. Do you know, and I haven't checked, so I plead my ignorance now. Have we changed, did the IDPH website change? I guess I'm going out there now just to reflect those new metrics. I'm checking now.
Yes, they align with the CDC.
Okay, I'm just looking at the regional details though. It looks like we're still we've postponed and stopped, posting obviously the percentages and all that type of stuff still, but I was hoping that they would maybe have changed the website around to kind of reflect those same numbers that details that you captured, but okay.
Yeah, I think they're a little bit behind the CDC site, but today we're at 258 per 100,000.
Well, on that old regional link that maybe you're at, there is a link there to go to the new, the only thing they roll up is for Region 4 is hospital, then everything else there is the individual counties.
Yeah, I'm seeing that now. Okay. All right. Okay, great. So thank you, team, for that update. And we'll move on. Any questions for Greg or Kara? All right. And as Beth is not on, again, I'll pause here for any of the health departments if they needed to share or would like to share any information.
One other thing, the Illinois, the Surge Center that they were using for the contact tracing, sunsetted last night. So today's the first day where they're no longer accepting calls. Every new case will be getting a text message with information, links on what to do, but all those calls will then be rerouted to the local health departments if they need any other further information. So just so you know, if you hear about that, the Surge Center isn't actually speaking with anyone any longer.
Thanks, Kara. Any other health department updates? Nope. Okay, we'll press on. Our STARS partners, any of our STARS partners join? I don't know if Sam jumped on late. No. Well, what I'll do is I will put let me see if I'll put Lee on the spot for a second. If he wants to give an update from our last meeting, what we had with the STARS team and the St. Louis Healthcare Coalition. If you want to provide any details from that last meeting, could you do that for us?
Sure. So we met with the folks from, like Phil said, the STARS training and for the public health and healthcare side, as well as the St. Louis Healthcare Coalition on the topic of doing some joint training. There's some opportunities that that because of the size of St. Louis and the way the state of Missouri functions or doesn't function, they're unable to get some of the training that we are able to get through our federal partners. So we're working kind of we'll do A if you do B, and trying to bring in a wider variety of opportunities across the larger spectrum than what we've done previously. We've had some discussion about more pediatric related training as well as more burn related training, trying to help beef up those areas where we're weak on this side, but for their side, trying to, again, do some of the things that we are a little stronger at, as well as some new materials that would just help across both sides. We also discussed more of a collaborative on exercise, since, let's face it, on our side of the river, if something happens, we're typically sending it to their side. They have concern if we have a large scale event that, they may not be able to accommodate because it's affecting them as well. So we're going to try to do more exercises where that's a factor that we have to kind of plan around and try to find solutions. So there'll be more to come. It's a very early stage conversation at this point, trying to really kind of outline where we want to go with it and the way we're going to get there. But overall, it was very, very beneficial. We got a great bit of information and a lot accomplished in a short period of time. So hopefully that'll continue and we'll be able to share more in the very near future.
Indeed. Thanks, Lee. Any questions? Okay. No questions. We'll proceed on to Reamer. Mike, are you on? Once, twice, thrice. I know I heard him in a conversation in the other room. So if Mike's not on, I'm gonna put Lee on spot again. If you want to kind of give just a quick update with what we're doing this weekend.
So yeah, Remert will be supporting MedStar for the NASCAR. We'll be providing ALS and BLS response for basically any fill in the blank kind of hole you need. We are also going to deploy one of the new tents that we purchased for the region as a portable, not quite a field hospital, more of just a treatment station. But we will be deploying that for the first time. New photos to come. I will say it took about 2 hours and 10 guys to really get it up the first time, but we were able to get it up and operating, and everything's gone well. We've been working with John on the planning for this, and it's been very beneficial. We've, I think, gotten a pretty good gist on how things are going to go with future events.
Thanks, Lee. I know Eric has his hand raised. Go ahead, Eric.
I do. When did we get a new tent?
That was a Remert purchase. What year was that? That was 2 years ago now. I believe it was 2020, the 2021 grant, the no cost extension on that one. Go ahead.
That's Eric, that's the reason we went and pulled that field hospital trailer from your facility. For those that aren't aware, our old tents that we had for the field hospital had we'll call it a series of catastrophic failures when they were deployed during the Belleville Marathon. On 2 separate occasions, the tents ripped. They were inflatable, and the cost to repair the tent to get it to hold air was more than to actually replace the tent. So we chose to do just that. We replaced the tents with Western shelters that are not inflatable. They don't require any extra resources besides some manpower to put them up. So we did purchase those, and they are, now on the trailer that is stored typically at Anderson, that's been deployed out for some of the community events and things. And if assistance is needed for those and for setting them up, we do have a couple of guys now within Remert who are comfortable with that process.
Awesome.
And they are labeled, we thought, with stenciled, I guess, with our Hope Coalition on them. I thought they were going to be on both sides and in the top, but it looks like it was just on one side, the short side. So we'll maybe in the future, a few things we had noticed that we want to make sure we get, like a Red Cross for the top, and a few other things. So probably going to be some of what we spend this next year's grant on in filling those. I don't call them shortfalls, but just trying to make it a little more visible for the public. And before we get here into the weekend, I think they're capping the event, correct me if I'm wrong, at 65,000 tickets. So imagine that, and then all the workers and staff that will be participating. So we'll balloon up pretty good here this weekend. And I would just ask that, for the hospitals that are here and the EMS folks that are here, just kind of be on your leaning as far forward as you can. I don't think there's a lot of folks bringing in a ton of extra staff. I think the planning that has gone into this, while it has been hectic, has been sufficient on our side of it. And NASCAR is used to running these type of events. But it's kind of a big deal for us this weekend. So hopefully we don't see anything come out of it and everybody's just able to enjoy the event. But I would just make sure that you're informing your teams and the hospitals around here that it is going on, and should something happen, that they're going to definitely want to be paying attention to the EMS R4 radio. Make sure you got EM Resource up. The team will be using EM Track to track the patients. That's what we do for all major pre-planned events. I know Mike did a lot of work with Dan Lee this past week to discuss or to set up the incident and have everything ready to go. And I'm sure John and I know Lee have been working with that. But we do that every time we have any type of a major event, to the point where Dan Lee asked Mike, he said, "Hey, you got to give a briefing at the next IDPH summit." I know this one's canceled this year, but maybe next year Mike will be able to do that, because we have found some value added there in these pre-planned events versus the day-to-day use of it, because I know we're not using it in that regard that much. So good work, and hopefully on the other side of this we'll have some good after actions and to help planning efforts for all future events. So thanks to the entire REMERT team. And again, another plug for that team. You don't have to have a medical degree or EMT or paramedic beside your name to join REMERT. There's lots of planning events and stuff like this that you don't need that type of expertise to be a great hand in setting up tents and or managing information. So if you ever want any more information, please reach out to myself, Mike, Gilbert, Lee, or Eric, John. More than willing to get you squared away. All right. Quick decon training update. Lee, I'm keeping you on the hot seat.
Okay, so our first full decon training will be actually Friday at Jersey Community Hospital, or Jersey County Hospital. We have, I think last I looked, like 16 students registered from across the region, as well as a couple of folks that are coming over from the Missouri side to kind of take a look at what we're doing. Overall, we've done a great deal of work within the office trying to ensure that the new PowerPoint deck is ready. This will be our beta, if you will. It'll be our first public beta, as Microsoft says. So I'm sure we'll find some bugs along the way, but this is going to get us a more refined program and help us make this even more successful than it's been previously. We do have another class coming up in August. I believe it's August 11th. That'll be here at Belleville Memorial. And then we are still kind of in discussions with our southern hospitals about doing some joint course down there. If there's any other facility that is interested in hosting or conducting a class, please do definitely reach out. You can reach out to Phil, myself, Eric, or Scott. Any of us will be happy to kind of get that ball rolling and start that discussion. Really, other than that, I think we're in pretty good shape.
Thanks, Lee. We are potentially going to make one other attempt at a train the trainer course. But again, as I've recommended to the folks through our BJC, through our system, and to the folks across the St. Louis region, is that if you are looking to put somebody in one of those positions, and if you'd like them to become an instructor, please make sure that that candidate is fully committed, to doing so and has a background, preferably in hazmat. Maybe they work for local fire department as a volunteer or something like that. You really, really want to have someone who is pretty adept at instructing or has the chops to teach and has taught before. But again, they just have to be very willing and able to kind of dig in. So I'll get off of that soapbox.
Actually, Phil, I want to jump back on that soapbox for a split second, if I may. And actually, I want to kind of throw Eric Brandmeier a little under the bus on this one. Eric's helped teach classes with us a couple of times. I'd just like to get his perspective as an instructor on this who doesn't do it as a routine thing. What you think about it there, Eric, as far as qualifications?
I'd be happy to throw myself under the bus. I know I've been very straightforward with Phil and Lee on this, is the fact that I have taught a lot in my career. I had the opportunity to teach a lot is the way I look at it. Even a class that I teach all the time, ITLS, for instance. I've been on that for a long time, and ACLS. I'm just one of those people that regardless of what I'm teaching, I always review it. When you guys started talking about it, I started thinking, wow, I wonder if there's a necessity to, and I think there should be, in my opinion, just so you know, that if you're one of these trainers of the train to trainer program, you need to teach it, I don't know, one a year. And I haven't done that. I haven't taught one for a while. And that's what, it's funny you picked on me, because I was thinking, wow, I really need to do that. Because like I've told both of you guys, and I'm telling everybody on this call, that is a particular part that does not come natural to me. Hazmat is not my thing. I took the training, which was, and I still hold to it. It's a wonderful class. And I learned a lot as I was learning to be a trainer. So the bottom line is, I kind of echo what Phil says, and that's the fact that, boy, if you're going to do this, you really need to stay up on it. Or in my case, what I will tell you is, if I ever shake the rust off and go back out and help Lee or Eric or any of the guys who are running these classes, or if we get around to hosting one here at our place, it's going to take days for me to get back to where I feel comfortable to teach it. So how's that?
No, I appreciate it. Thank you.
Thank you, Eric, for the perspective. Again, if you got somebody in mind, just reach out to us and we will we'll probably have to interview them a little bit, but we'll definitely take it under consideration. All right. Pediatrics, I know Eric had to step out, but he did not have any major updates. He did have one question, I do believe, for Brad. Apparently there was a position that was open that was supposed to be getting filled on the, he said it was a nursing position. Do you know if that position has been filled, Brad?
Yes, you're talking about the EMSC regional coordinator. That they do have co-chairs. I'm sorry, I'm traveling to the NASCAR meeting right now, but I do not have their names, but they have met with Kelly Jones and started the process and training and so forth of being able to take off running with that position. So I will make sure when I get back that both of those candidates have Eric's contact information, Eric has their contact information so that they can hook up and continue on from there.
Appreciate it. Thanks, Brad. All right. And again, another plug for EDAP. For those EDAP facilities out there, when's the last time you take a look at that EDAP checklist? Run through it and see if that water's running between 98 and 110 degrees Fahrenheit for your decon area. Check, the small things would always help you out. All right. Grant status.
Phil,
oh, go ahead.
Phil, can I bother you for just 1 second? Interrupt.
Sure.
On NASCAR again. there was talk of a notification letter going from the racetrack to all the hospitals. Does anybody know if that occurred? Because I'm not sure how many of our hospitals are on here, but we had talked about a letter going to the EDs of the hospitals so that everybody was aware that NASCAR was happening. I have not seen that letter come across my email. I was just curious, since Brad's going to that meeting, maybe he could check on that.
Greg, it's John. I'm here at this meeting now, getting ready to walk into it. That is a #1 priority on my list, is to get that from their PR person so that we could pass that off to Phil so he could get that information out to everyone.
Okay, great. Perfect. Thank you, John.
That will include their, again, you know, there's things that change on them that they have no control over, but it's going to give you a pretty good outline starting Thursday through Sunday of everything that's happening and what time it's happening. So.
Great. Good work.
And this is Lee, Greg. I did send out an email that was forwarded to me by Brad Perry to the hospitals that were closest to the track. But until I had final information, we didn't send anything else out, just because, like John said, it's changed on us more times than I can count.
Great. I just want everybody to be aware, you know, it's just possible that some hospitals may not be aware that this is going on.
Indeed. Indeed. And it will go out.
Phil, can I just?
Yes, go ahead.
Sorry, can I just add one more thing to this? Because we do have a lot of hospitals that are in attendance and so forth, and we are going to send this out. One thing we do have to pay attention, because it actually starts today, is that our camper population is going to dramatically increase. There's over 600 camping spots. And that number includes the one inside. If we subtract the 65 from the inside, that's how many exterior camping spots that are going to start being occupied as early as today. So our camping population is beginning much quicker than Friday. And, you know, that brings along not just the attendance daytime, but that's also nighttime and the activities that are involved with these campers. And, you know, I don't know how much drinking and partying that goes on at these campsites at nighttime, but if I was to guess, it'd probably be considerable. So, but that begins today.
Thank you, Brad. So, and when I do receive that, it will go out by EM Resource and just through our distro list that we have here as well. But again, one of the reasons why I reminded everybody earlier, I would just ask that, you know, I know staffing isn't always, you know, the best, especially lately, but at least that you're on your toes, you've kind of run through the mental gymnastics, and you've at least talked to your folks about what the possibilities are and during what time frame. Just people being in the know kind of helps. So thank you all for that.
And with that being said, sir, I'm going to appreciate everybody. But I am going to step off this meeting so I can get into the NASCAR meeting.
Indeed. Thanks, John. As far as grant status, so yes, I've reviewed the current, when we say NOFO, Notice of Funding Opportunity, there are no true major changes from previous years. We're going to be pretty much in line with what we've done the past 5 years. One thing that is a change for those folks that do submit project proposals for, let's say, medications, you have to have a policy that dictates how you are going to maintain that medication. So your hospital policy will have to be uploaded into eGrams. We are still using eGrams this year until we get to Amplifund, hopefully next year. But that policy will have to be a part of your package this year that gets uploaded into eGrams. So, and I will work with those who do put in for that. Eric, I will say, I know normally Sue would submit annually for some of that to update their Cipro and Doxy or what have you at Staunton, but we hadn't had to have a requirement for those for that policy. And I know we traditionally will procure, just like we're about to do the end of this year with the remaining funds, additional duodotes and the like to support the KIMPAC, our quick reaction portion of the KIMPAC. So we'll have to do that in this upcoming year as well. So I'm working with my pharmacy team. If you do plan on submitting a project proposal that contains some form of pharmaceuticals, and I would say I don't think that's if you're getting maybe like what Remert does for they normally get maybe IV tubing catheters, and they may get some saline. So I don't think we need it for that. But when we're talking about these drugs that we have to maintain long shelf lives, year after year, that's why I brought up Doxy and Cipro as the kind of use cases. Those will require you to have a policy on how you plan to maintain, procure, exchange, replenish those drugs. So, and we'll work with you on that. All right. The project proposals for FY24 will start opening up 1 July. So, and that goes 23 to 24. So the grant starting 1 July 2023, those project proposals open up per our documentation, our bylaws on 1 July, and will close on 31 December. So please start thinking about what you want or what you need, and make sure that you get those submitted. So that link will go out as soon as it opens up. You can see it right now in Member Planet, but please don't put anything in there until 1 July. I didn't close it. It's just open right now, but it will close on 31 December. Your project requests this year, they've always had 4 primary components to them. They were basically attend meetings, check, conduct their HVA annually, or participate in the region's HVA, participate in exercises, and review plans. Those are the 4 components. Those will always remain in any of our subawards. But for those, we've had some pretty large subawards, $24,000, $25,000 subawards. For those, we're going to be looking at those pretty closely with the amount of funds that we are providing. And some of those will come with an additional addition, so a 5th piece, and that may be hosting a training, hosting a subcommittee, or some form of assistance with a coalition project. So please, we're not going to make it a standard for everyone, but we will be looking at each individually. So in the past, some of the things that have occurred is we've had folks host at the time when we were conducting what we'd call the Mercy now, but the Coalition Surge test, we'd have good folks at St. Anthony's host that. So they would have a room for us and all that type of stuff. But we haven't had to do a lot of those because we haven't had a lot of face-to-face things going on. So, we may include decon trainings or those type of things, host, 2 decon trainings at your facility. That means, providing the space, et cetera, and having the gear, what we, supplement what we don't have. Or managing a subcommittee, maybe running the training exercise planning workshop. I know Eric ran that. We did that this past September. So things like that will be in those contracts going forward. So please keep that in mind when you are submitting your project proposals. A few key reminders with regard to your project proposals. Please ensure that your SAMS.gov information is up to date. We ran into a few of those where the names of organizations on paper versus what's what's on your building versus what's in SAMS.gov were kind of different and had to be resolved. We've really tried to work through those with those organizations. Please fully review your contract and the agreed upon dollar values that are in there versus what you may request reimbursement for. We had maybe one issue where that dollar value was, I think it was around $250 difference out of a $24,000 proposal. So not sure exactly how those were. We got two different numbers in the end, but what was signed and agreed upon was the lesser, the one that was $250 cheaper. Now, in the grand scheme of things, that's around 1% of the total award. So it's not that big a deal, but that could happen to where it's, 50% of the award, and your organization can't execute whatever they had planned because those balances were different. So I ask that you have some good scrutiny on there, and if you see something that comes back from the grants management office from GMO and it says, and you can go, oh, that's not what the number I had in my proposal, and then we can fix it then, because once you sign it, then we're kind of stuck to that number and got to jump through hoops to get that fixed. In this case, $250 probably wasn't that big a deal overall. You can make some adjustments, get something maybe a little bit cheaper, and maybe prices have gone down. And also remember to submit copies of the quotes for what you are proposing along with your proposal to project requests at swillhope.org. So copies of those quotes, we need those as well when you're doing it. It makes things a heck of a lot easier. Any questions on any grant related information?
So we really have no idea when we're going to get this year's grant.
When you say this year's, which year? FY22 or which?
Well, the one that usually expires the end of June.
Mm-hmm. So if you haven't, and I have to look back because I don't know them all off the top of my head. I know we had 7 subawards for this year. And I know we've got 7 subawards for FY22, the grant that we're currently in. And we've got, I think, 6 subawards for FY23, which begins 1 July. And again, we haven't even submitted those. So I don't, I'd have to look at yours. But Nancy, if you haven't received anything back, I'm not sure that you have a subaward. So I will check and follow up with you after this.
Well, I sent 3 project requests, and I mean, as far as I know, we haven't, received anything that says you can go ahead and purchase items.
Yeah, because I don't see one for you for FY22 is what I'm looking at now. Now it may be one for FY23, but again, I'll have to follow up with you right after this call.
Okay.
Any other questions?
Hey, Phil.
Yep, go ahead, Greg.
Yeah. So on IMATs, just to go back to IMATs, which of course is a requirement that everybody had. I reiterate what you said, everybody needs to go in, but I went in recently and just kind of started poking around to our hospitals. There are a couple hospitals that we have both hospitals in there twice, with the health departments as the administrators of one of them, and then hospital people as administrators of the other. I'm not quite sure why that is occurring, but that can be very, very confusing that we have hospitals with health department as the administrators. So my request to both health departments and hospitals is, yes, get yourself signed in. Also go look up your facility. Make sure that your facility is only in there once, and that the proper people are the administrators. And if the health departments for some reason are on health departments, I think those names need to be changed so that it's clear that this is the health department that has set up. So they, like if they've, I mean, the only thing I can think of is that they've got it set up to receive products specifically for that hospital, but that's going to be very confusing in a response if we have health departments actually controlling a hospital and then a hospital controlling a hospital. So, like I said, just please go on and not just get your login working correctly. Go in and review the facility and who is in there and make sure that it is all correct.
Thank you, Greg. Yeah, now those are great points because yeah, it can be very confusing. So please make sure that that information is correct inside of IMATS. All right. Moving over to 2022 plans review. So as every year, this is going to be a requirement with regard to our plans and our bylaws each year. As we kind of talked about late last fall, when we finished up the review of our the FY 2021 or FY 2022, excuse me, plan review. This one will be conducted a little bit sooner. I think we had a target date last year of 15 December. We approved those plans on, I believe, 1 December of last year at our final quarterly meeting of that year. My goal this year is to, again, move that up 3 months, so to the end of the first quarter this year. So what we're going to be doing, and I guess it should say 2023, but it'll occur in 2022, but it'll be the FY23 year. What we're going to be looking to do is knock those out by September of this year. We'll talk about that here in a moment. So things that you want to kind of take a look out for this year is that we're adding, or ASPR's asked us to put together a radiation response annex for the coalition. I'm going to let Lee kind of talk about it. One thing I will say is that this is something that as soon as we saw it, I know Lee jumped on it and just started putting stuff together. You know, we used our basic template and started going through, filling in information. This one is a little more robust than some others, not as robust as the ChemPact one, but it is a little more, has a little more meat to it, especially with regard to the patient care side. So I'm going to let Lee kind of talk about 2 or 3 of these slides, and then we'll talk about the burn surge annex and our tabletop. So Lee, if you want to kind of take over here.
Yeah, sure enough. So when we looked at the original radiation annex, I mean, to be honest with you, when we look at our HVA, RAD is very, very low. We don't face a high risk of a radiological event here just because of our lack of any real radiological industry in this region. However, the obligation was still there to do a plan. And in looking at it and with collaboration with some of our Missouri counterparts and for those that aren't aware, we do have a small RAD component in North County in a landfill that's on fire. So, you know, there's that. But we looked at it, figured this is probably something we don't see a lot of. So Eric and I and Phil, as well as Scott Klosterman, we did a little digging and I started putting together the basic outline. Then I'll tell you right now, the first thing in the plan basically states that this is low on our HVA, which is why, you know, we don't have more on RAD. We are looking to bring RAD training into the region to support this and to help facilitate additional knowledge. What it does do, though, is it will identify roles and responsibilities for basically the coalition members. So from EMS to fire to hospitals to resource hospitals to the RHCC and through the chain of how that should flow effectively. It'll give some basic high-level information about radiation because we recognize, again, this isn't something that, and we've seen this in the decon training, this is the one section that everyone seems to fear is radiation. I know we can't see it, we can't taste it, you can't feel it, it's still there, so we still got to be aware of it. So this goes into some of that, and it also talks about the various triggers that'll activate this plan. There is, and I'll be perfectly honest, I blatantly stole the radiation safety information sheet from the city of New York. It's a phenomenal good handout that if we ever have it, you can print it en masse and give it to your staff. And it is designed to give them a high level familiarization with radiological responses and things that, you know, they should and shouldn't be worried about, basically. to kind of help set them at ease and give them a better understanding of what their risks really are, because a lot of times they are blown out of proportion. Phil, if you want to bounce to the next one. In this, it also does go over the triage for radiation-related injuries. The information is pulled from the REM, the Radiological Emergency Medical Management of Medical Incidents, which is part of a federal program from NIH. We also reference materials from the Merck manual as well as the Air Force's biodosimetry. They have an entire shop that does nothing but this. We reference their information and a few other valid and reputable resources. We've got some basic treatment and injury prevention information that comes through, again, through REM and through the Radiation Injury Treatment Network. We did collaborate somewhat with our written hospital, which is Barnes here in St. Louis. They actually have the Radiation Injury Treatment Network accreditation for that stuff. We've talked with them some. We are planning to do more with them, especially in a training component for exercising and just making sure that the plan follows through in full. And Phil, if you can hit the next slide. And just finally, the other thing that this goes into, because again, it's not something we see, kind of like monkeypox. We just don't see it often enough to recognize it immediately. So it does go over basic information for, identifying radiological syndromes and injuries. The differences being things that, just like any biological agent, you're not necessarily going to see the illness initially. It may be a delayed reaction that you begin to see things. And it kind of discusses that. And again, that information is pulled from reputable resources and referenced in a way that it's actually usable. So we'll send the plan out. We definitely want feedback because it is something that, again, we don't see a lot of in our current, our current situation, as it were. There's not a whole lot of threats, so there's not a lot of consideration. So more information is better. But that's pretty much all I've got on the RAD side. I do want to point out the upcoming Burn Surge Tabletop will actually include some RAD component to it, because realistically, if we see a radiological incident, it is going to include some kinds of burn. So we did factor some of that in just as a forewarning that there'll be material coming from both annexes that are going out.
Thanks, Lee. So I'll continue before taking any questions with the Burn Surge Annex, which will also be going out for approval. So again, we're required this year to conduct a burn surge exercise. So that's why we'll kind of have a dual wielding exercise to kind of meet, kill two birds with one stone, if you will. Things to remember is that this Burn Surge Annex does not provide patient care information, basically due to IDPH's exhaustive ESF8 Burn Surge Annex. It has tons of information. I mean, to be quite honest, the fact that we're doing a Burn Surge Annex, and it's literally probably will be less than, I think it's going to end up being 8 pages maybe, is a testament to what IDPH did in the state's ESF8 Burn Surge Annex. It is done very well, and it has, I think maybe it could be organized a little bit different, but as far as treatment information and all the information that you would probably need during this, who to contact, when to contact, all of that is in that annex. So this one will be much slimmer than the radiation annex or our ChemPAC annex or any of the larger annexes that we have for the region. So that's a good thing. So this probably won't take much for you to digest and provide comment on. It does provide our coalition strategy for balancing a surge of burn patients, which could be with anything, the same way we do it with if, again, we have a tornado and we're looking at pressure injuries and just general lacerations or whatnot, and people getting transported from, after a tornado, we're going to always try to load balance as best we can. But this plan does not have a ton of details in it. A few of the things that it will kind of try to detail out is how we can best prepare our organizations with regard to supplies, equipments and supplies. So as you're kind of looking, you're seeing a kind of a snapshot inside of what you'll see later. It's basically taking the burn surge cache of supplies that's listed in IDPH's ESF 8 burn surge annex, and kind of tailoring it for a specific duration and a specific amount of patients. The burn surge cache that's listed in the IDPH annex is basically for 10 patients. Doesn't provide a time there, but so we went through and did a few things. What we did try to take a look at is the simple fact that I'll take Boyd, for example. Boyd probably shouldn't have as many supplies on hand as, let's say, Barnes, big Barnes, right? You're gonna take a 25-bed facility that probably has an average daily census of 6 or 7 to a 1,000-bed facility. You know, it probably shouldn't, you know, that's a trauma center, probably shouldn't be equipped the same. So we're kind of trying to tailor that because we do understand that, one, we're probably not going to see a ton of burn patients in our region because, you know, we don't have wildfires. We do have a few structural areas. We do have a few hazardous materials locations and refineries in and around our area, which could contribute to that. But again, much like the radiation side of the house, this is very low on our HVA. So we don't want folks to be over-prepared and hold on to highly expensive items, because some things on here are, you know, when it comes to patient care supplies, are very expensive that'll just go bad over time. We don't want you to have to hold on to you know, an abundance of those. We'd like to get those into the folks' right hand. We'd like to basically make sure that you have what you need for the size of hospital facility that you have and what you could see. And it will include a basic checklist for all providers doing a region-wide level 3 or higher response. So what that means is, just like the KIMPAC one, it'll be pretty much a stepwise checklist that'll kind of take you through you know, the normal things of any response and some burn surge reminders. These are some things that you should be looking for if you get that EM resource email and text that says, hey, we've activated the burn surge annex, we have a level 3 response or level 2 response. You'll be able to identify what that kind of means, because we do have our response triggers listed like we do in all of our other annexes. So you can kind of talk to that for your staff and your administrators at your hospital and what that entails, and we'll walk you through everything else. And a lot of it's going to point you to the ESF 8 plan, because again, it is highly detailed and very prescriptive on what needs to happen when we have a burn surge going on in our region. So I'm going to pause there for a second and open up for any questions with regard to either annex. Okay, so barring any questions, what you guys can expect to see from us today, when I normally send out after our meetings, hey, here's the link to the YouTube video and playback, so if you missed it, and we'll have a quick synopsis of what we discussed here regarding the plans, and it'll have a link there for you guys to go out and look at all the, you know, the 2020, the ones we had dated December 1st, 2021. And it'll have a link to the comment and review matrix as well that you can fill out and provide comments on. The goal, we'll take a look at them each month, you know, so we're going to have we'll have our July meeting, our August meeting before September, but we'll be looking to approve the plans on our quarterly September meeting. So this gives you upwards of 90 days to review everything until that date. I think that date is what, September 6th or somewhere around there, or September 7th, I believe. Let's take a look. Yep, it'll be September 7th will be our next quarterly meeting, but we'll be looking to approve those plans by that point and just tuck this one away for the next year. Okay, any questions? So here are a few follow-up things. So the burn surge annex, again, that tabletop exercise is on the 22nd from 1300 to 1500 hours. And again, it will focus on how that plan can be implemented and determining what your current capabilities to support a burn surge or radiation incident across the region. For those of you that everyone should have got a copy of the slides via PDF through email. That link that's there will take you directly to signing up for that tabletop exercise, and we will, I think it'll be actually a really good exercise. we took a few cues from a few areas around the United States. And I think at least the exercise will be somewhat realistic and plausible for us to deal with.
Are you sending that out via Member Planet with a link for people who are not on this call? I mean,
Yeah, it already went.
I'm not
it
quite
went
sure
out.
everybody understands that link is how you register.
Yeah, you'll have to register on that link that you see here. But yes, it's already gone out, I believe, twice already. We'll send out another one before the incident, before the exercise. But that link that you see right there will take you to sign up through Member Planet, just so we know who's going to be attending, and so when we send out copies of the slides and etc., we'll have your name and those points of contact.
Okay.
And that's basically what the timeline is going to help us with right here. This is our timeline: burn surge, NX review, or excuse me, tabletop exercise on 22nd. There's your time to review starting today. You'll have access to all the plans. And again, we'll ask that you focus on the burn surge and radiation incident response annex, and then we'll approve all plans September 7th. So hopefully that will go off without a hitch. All right, we'll pause here. We're right at the hour time frame, and we normally schedule 2 hours for our quarterly. So you'll probably get some time back, but we will open the floor for questions, concerns.
Yeah, that's Greg again. You know, I always have concerns. So ChemPact. So we had a ChemPact exercise. I got a EM resource. Maybe the sign-up link went out. Something's wrong with the state. But I didn't participate in that. And other than the EM resource, that's all I got. Have we done an after action? Have we set up a time to redo our ChemPact plan? The reason I bring this up is that I'm reviewing some EMS stuff that is definitely incorrect, that needs to, go along with what's going in the ChemPact plan. And we are going to be resuming EMS system site visits to go to participating hospitals, associate hospitals, and all of those hospitals are going to have their individual ChemPact plans that match what's in the regional plan. So where are we at with that after action and adjusting the ChemPact plan regionally?
So, yep, we did the exercise. We conducted the AAR, was for all the participating folks that took part in it. So primarily it was Anderson Hospital, us here at Belleville, Staunton, MedStar. Eric, help me out with your ARIVAC folks. What's the name?
ARIVAC, yeah, and we also had Edwardsville Fire Department.
And Edwardsville Fire. Yep. So we conduct the exercise, and actually we went over it last month. We went over it last month in the monthly meeting with the highlights of what we discussed there. I'd say the actual after actions report is probably 85%. I would have finished it if I didn't go on a mini PTO vacation for my anniversary last week. So it's pretty much almost done. So if you found any feedback or items that you want or that you think need to be included, I'm not sure. Greg, if you just want to send me any notes that you do have, and I can take a look at it and see if it impacted. But I think we found pretty much what we needed to find out with the exercise, and will be in the actual AAR when it's all said and done. So I would say,
is that going to be sent out to everybody? The reason that I'm saying all this is I think a lot of the stuff that's done in a bubble with just the people who ended up signing up is causing areas of concern with who this all affects. There's a lot of people that this affects. And even though I didn't participate in it because, quite frankly, I never saw an invite. As I said, that could be I saw it on the calendar, but I was expecting an invite. I don't usually go off of slides that get sent out to register for something. I usually expect it, and that is my problem. I've learned that this time. That and I received nothing. I didn't even receive a phone call that we're notifying IDPH, which is part of the state plan, that the REMSC would be notified when the plan has been activated. So that would be an after action thing that I would have added. But I'm just saying, I think some of these things we're doing are in such a bubble that these questions don't come up until I get an entire SOG plan from a hospital and their EMS is contacting the RHCC for ChemPAC. Well, that's absolutely incorrect. They're not contacting the RHCC to, you know what I mean? But you don't know that I got that, and I don't know what you guys got when we're not sharing a lot of this information with everybody that can generate these questions. And if I'm wrong and I'm just doing it incorrectly, I will stand corrected and everybody can tell me. But it does seem like some of this stuff is not getting shared widely so there can be comments from other people.
Well, this one, I'll say this, the exercise in and of itself was limited in scope to those who were participating in it. So the folks that I did outside of the EM resource notification, those were the only players. Those were only the direct players. Everyone else were indirect players through EM resource and had to update and reading whatever updates were sent through EM resource. And again, that's why we went over it. We covered it in, we went over the after actions, what we got out of the after actions in the last meeting and on the May or whatever meeting whenever we conducted last, because it was conducted on April the 29th, and on the 4th, that was our May the 4th be with you Star Wars meeting. We talked about what occurred during that for the entire coalition. So for everybody who attended that meeting, it was there. So we went over what occurred there, had opportunity for questions, concerns, and we posted that to the YouTube page so folks can review it, and they will see what the full after action report details out as soon as it's done. So we're right at 30 days. Again, we wanted to get it done at 30 days, so it'll be done this week and go out so folks can review the after actions. But as far as your piece, but as far as your piece,
we did going to happen. Go ahead. I'm sorry.
I'm just saying, but as far as your piece, as far as conducting the call, we white sailed the call to you, but we didn't white sail the call to the IDP, or not the IDPH, but the IEMA. Oh wow, help me with the term.
The duty officer.
Yeah, the duty officer call. So we made those calls just to make sure that it works and asked them the questions. Hey, what would you do after I give you the call? And they said, okay, we would contact that, and that went off without a hitch. So, but we did white sell your call.
And I'm not trying to criticize all this. I'm just saying that, and I'm going to go back to the Bay Forest and cover it and look and see what the hell I missed. Maybe I got a call in the middle of it and didn't pay attention, but I just don't always know that all 19 of our hospitals are on that call. And if we don't get some kind of documentation,
there was no call. I think that's the thing. There was no call. All of this was functional and moving parts outside of EM resource and what went over EMSR4. We didn't, in no other entity outside of the 5 I named participated indirect. So that's I'm
just saying that my expectation when I go to these EMS providers is that they're going to be able to tell me this is their ChemPAC plan. And when I go to the resource hospitals and the associated and the participating hospitals, I expect them to present a piece of paper that says, this is what we're going to do if we need to activate. I understand we have a regional plan, but these folks at that level have to have these plans, and they need to mesh with our regional plan. And I just feel like we need to get some actual documentation so that they know how it's supposed to work and what we're going to change so that they can update their plans. And I know we do a plan and we, send it out for comment and some people see it. I just feel like we need to carpet bomb a little bit of it so that these folks, and I don't mean the entire coalition, there's no reason for mental health necessarily to know what the ChemPAC plan is, but I mean definitely our hospitals and our EMS, because they play such an important part of ChemPAC. That's my only request, is that somehow we make sure that they understand, because if we don't, then the exercise is useless, in my opinion.
Indeed. Go ahead, Mike. I see you raised your hand.
So I just want, Greg, we did send out a request to every resource hospital to participate in this drill, and only us and Anderson were the ones that responded back to it. So we did include every resource hospital to participate in this drill, and Anderson and us were the only two that responded to it.
No, and I'm saying this could be my problem with the state. If I wasn't invited, then that's a problem. But if I was invited and I didn't see it, then that's on me. I agree with that. But if I wasn't invited, I should have been invited. But that's not what I'm here to argue. I'm just arguing that I think we do this and we get it and we check off the box that we did a regional plan. But if we don't get it to our hospitals, we don't get it to our EMS personnel, then what got sent to me last week from an EMS SOG plan, in which is totally incorrect, you know what I mean? It's like, how do they not know that it isn't to call the RHCC? It isn't to call the RHCC to request the ChemPAC, unless you have that in your plan. I did not read that in the plan, but it is not to call you, correct, Phil?
Correct.
Yeah. So I'm just saying, I just feel like we're not getting the information to the most important people who actually have a hand in this. That's just what I'm saying. And I'm just bringing it up for us to all, kind of acknowledge. I don't know if any of the other hospitals, feel like, no, we're getting plenty of information on this and we know how we're supposed to go, then it's back on me. But I just feel like it doesn't seem like it's getting disseminated correctly.
Well, this is Chuck
And now
from
I'm upset
MedStart. This is Chuck from MedStart. I mean, and I'm thankful, but Jeremy Gottheimer and Kim have been starting to attend these meetings, which has been in Abbott. The big problem is participation from the managerial level, so we can get that information disseminated. Because, I mean, if I wasn't involved in emergency management for a long time prior to this, half of our staff don't really know about ChemPAC, but our managerial staff do know about ChemPAC and how to activate it if it's needed. So Phil and Mike, you do a great job keeping our system informed of the information that we need to activate those things. I mean, I knew when the exercises were going on. I got the alerts and knew it was happening.
That's fine. I mean, I just think that some of our providers don't even know that they're assigned. I mean, I think people who were on our call in May knew, but that some of our providers don't know that they're actually assigned to a certain to a certain Kenpack hospital. Our hospitals are assigned to a certain Kenpack hospitals, and they're not all the 2 Kenpack hospitals in our region. And I just think that, you know, we need to do the exercise. We need to do the after action, you know, possibly together. I know we don't have input, but it's great to hear. And, you know, I mean, I certainly participated in after actions where I wasn't in the exercise, but I've come up with things that I notice as they're going through it. So, I mean, that's just my opinion. And like I said, now I'm shutting up.
And Eric, I see your hand. Go ahead.
Yes, sir. I just want to comment on the fact that I think I'm one of the old guys who's been here through this whole thing. I remember when my facility became a Kenpack hospital. That's because a different facility in East St. Louis closed. That's why Anderson is a Kenpack hospital. So let's go back to that. That puts in perspective what the level of thought, not only here at our region, but throughout the state was as far as getting the message out about Kenpack. And I can tell you that becoming a Kenpack hospital, it's always been kind of, I don't know, funny, humorous. The message you get about Kenpack, it's like, okay, tell people who need to know, but don't tell everybody. So who needs to know? You know, why you would argue that the people in your facility need to know, because they need to know what they're understanding when somebody calls for a Kenpack. And then from, you know, like from an EMS system, because we have the opportunity to be that as well. You know, I can tell you that once a year, I remind our EMS leadership that we are a Kenpack hospital. Memorial in Belleville is a Kenpack hospital. This is what this means to you. That's the level of where we're at. So like Greg said, these exercises are great, because I can tell you that the chief of Edwardsville Fire Department, I leaned on him to play in this exercise, because he was instrumental in planning the big one that we had planned for April of 2020. So he deserved it to have the opportunity to play in this scaled down one. But to his credit, he amped it up. He amped it up a little bit and recognized the fact of the lack of knowledge that the boots on the ground people had, and I think he made it very clear to his staff and to us how unsafe some of our people are in boots on the ground setting. And I argue it's because of the convoluted message which has come down from the top, as far as who needs to know, what do we need to know, and what do we have to have in place. And that's why an exercise like this, and I feel Greg's pain if he was not made aware of it, but we need to at least have the people, the EMS services. Chuck, thanks for speaking up. Like the ambulance service as vast as yours. People need to understand, first of all, wow, you don't walk into something like this. You know, it's a classic canary in a coal mine. And one of the things I can tell you from our brief after action review that we had, Phil, was the fact that we really don't have enough stuff. And is it logistically accurate to order enough stuff when we know it's just going to continue to expire, because it is a low possibility, high impact threat. So there's a lot of mess to clean up, but the only way we're going to be able to do this is make this a little bit more open to everybody, and certainly those hospitals who have EMS systems.
Yeah, and Eric, I agree 100%, because when Kenpack started, you signed confidentiality agreements. And if I didn't make that in my training last month clear, Kenpack is known now. You can Google Kenpack. The only thing that is tried to keep on, I don't know, down low, whatever you want to call it, is actually where the Kenpacks are located. And that is safety on the part of the hospitals themselves, should there be an actual terrorist attack. But no, it doesn't need to be the top secret thing that it started out to be 20 years ago or whatever. But that's not even the issue. It's the issue that I have, that our people don't even realize that, you know, there should be a plan, and it can be kept secret in the sense that the plan could be the EMS provider is calling their own resource hospital, and then the resource hospital knows which hospital they should contact. If you don't want to disseminate it all the way down to the EMR, that Anderson Hospital is their CAMPAC hospital, you know, you can go to Alt Memorial Resource. You contact the resource, they will need the CAMPAC, then Alt Memorial's ED should know that Anderson Hospital is their CAMPAC hospital, and they activate it. And that's the kind of information that I think we're not disseminating to people, because I'm not seeing it in their plans. And that's what I think as a coalition, we need to do. This isn't Phil's fault. This isn't Lee's fault. This is just us working as a coalition, that we need to work on all levels with the people that it really, you know, and I'll give you an example. Public health. Public health needs to know CAMPAC exists, but that's all really public health needs to know, is CAMPAC exists. We don't need to involve them in some big planning session, because they have no role in activating the CAMPAC. The afterwards, yes, they're going to have plenty to do afterwards, public health wise, but I just keep thinking we missed the boat on everybody knowing at the hospital and EMS level what their role in CAMPAC actually is. That's, you know, and these are just my opinions as I speak with people who don't know what's going on or whatever. I can't even, you know, necessarily, because we've gone on some EMS site surveys and they don't know what to do. Some of them know what CAMPAC is, but they don't really know who to contact. You can tell they're guessing when we ask them the question. And that's what we need to disseminate, this information and this education down through them. That's all I'm saying. And when I don't even get the information, you know, then we know why there is an issue on it. So that was my point. I certainly wasn't beating anybody up in it. But, you know, I just think we need to have some of these open discussions about what we might need to change to make sure that everybody's getting the information they need to get.
Hey, Greg, it's Lee. I have a question, and maybe I misunderstood this, but everything that you've described is actually outlined in the plan, which we did send out for review when it was originally rolled out. I mean, and that was sent out to all the HPPs. I know those changed, like in some instances as often as the weather, but at that point, when we sent it out to the facility, that should have been what they used to write their guideline from. Am I wrong?
Well, that is correct, but apparently, and I'm not trying to throw anybody under the bus, but what got put in was a copy and paste of national CAMPAC guidelines rather than regional and, you know,
who got what,
guidelines.
when you say what got put in where? I'm specific.
What got put in the actual standard operating guidelines, and once again, I'm trying not to you know, point fingers at anybody. When what got put into what is considered physician orders to EMS were basically national guidelines of CAMPAC, and not how we would actually activate the only change that I saw in the national guidelines, which are very generic, was that we contact the RHCC, and that isn't true. That isn't part of the plan. So when these people were writing them, and it wasn't just one person, nobody recognized that. And the only question I have is, why didn't we recognize it? Did our EMS systems know that this is actually what it is? Or are EMS systems so removed from our coalition that they're not getting, you know, the information? I guess that's what I'm trying to say. And sometimes, you know, you just have to kind of be beat in the head a little bit with too much information. And we all know we don't want too much information. I guess what I'm trying to say, repeated information, repeats of the same information, so that we know everybody actually got it.
Go ahead, Tina.
The only thing I was going to say for our facility is I knew about the Chem Pack and everything. I just forgot what it was going to be, apparently. But when we heard it, the one thing I did want to exercise is to stand up our decon team. And one thing that we did find out is that half of the team members were either on a leave or on vacation. So then internally, when you look to see who was here, was only 2 out of our 9 or 10 was actually here. And then trying to contact the others that might come in, we're taking another whole look at who else can help at least set up the equipment for us. And then the other thing is, when we did that Survey Monkey, will that be part of the AAR, the Survey Monkey that we did?
Are you talking about for this one specifically? Are you talking about for this one exercise specifically?
Yes, for the Chem Pack, when we went and did that Survey Monkey afterwards.
Yeah, so the survey you talking about when we requested how much of this do you maintain, et cetera. Yes, that information is being consolidated into, you know, a spreadsheet, so to speak. So we would be able to reply with that, you know, be able to post that information into the actual AAR. And so, Greg, just so I know we're going a little long on this, but just so I'm clear, you're talking about someone's guidelines. You weren't talking about the region plan. You were talking about someone in an EMS systems guidelines. They copied and pasted something into their plan. Is that what you're referring to?
Yeah.
Oh.
And actually 4 of 5 of our EMS guidelines. So I'm just of our EMS system. So that was concerning. Because it was reviewed by 4 system coordinators and 4 EMS medical directors. And, you know, and it could just be as simple as a simple mistake. But the bottom line is, I think we need, you know, and I have eyes on it. So, I mean, I'm a fail-safe person, you know, there obviously, but I just think that I just don't even, you know, feel like, you know, we know, I just don't think everybody has learned what we learned from this exercise that happened, and that we should know that, and what we're changing or going to change. And maybe that's all going to come. That was my original question was, are we going to take our learned things? Are we going to, you know, change our regional plan at all? And then are we going to send it out to everybody again so that we can all review it and then adjust our own plans at the local level, or our own guidance to our own staff members at the local level so they know what to do?
So, yep. So as on this slide, all the plans will go out, right? So everybody will definitely get a chance to see that. They'll have the AAR by that point in time. So they'll have that information as well. And just to be clear for everybody who's online, like we discussed in April and in March, this exercise was very limited in scope. So when you see the objectives were very limited in scope. For those of you who participated over the last 3.5 years when we were going to do our full scale exercise, that was very broad in scope. So you would have had a lot more to do in there. So this one, whereas the state, or I don't know if it's state or the feds, required us to do a communications exercise, we incorporated that piece. Hence the reason why we use EM Resource and me contacting the 24/7 state center, just, you know, as the plan and as our annex kind of dictates. And then the piece underneath that, what we really wanted to see was the length of time. This was really a race against the clock exercise. So that's why we used the folks that we used, and how we were able to, you know, say an event happened at this time, and when we stopped the clock is when those supplies made it to the scene. So again, very limited in scope, hence the reason why there was not a AAR there wasn't a after actions for everyone to sit in on. We really wanted to keep this very focused. And I think we did that. So I would encourage everyone to read the final product when it's done. So hopefully by Friday this week, it will be done. Again, tried to get it done last Friday, just couldn't make it before I had to leave out of town. So hopefully you guys will be able to read that. And again, when these plans go out every year, you know, I love getting administrative comments back, you know, like, hey, the period's missing, or this number is wrong, or what have you. But substantive comments are highly appreciated. Something that says, this is how we need to move during this time frame. I don't think this looks right, because when I get the call, this is what I have to do, da 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 da, and that's how that impacts everything. So substantive comments are really, really lacking majority of the time when folks have taken an opportunity to review these plans. So, and keep in mind, we have so just so everybody is clear, every year the state is going to have us review the bylaws. They're going to have us review all of our plans, and that's our primary emergency operations plan and 7 support annexes to go along with that. So again, that's a lot of information to try to digest. So I always encourage folks, don't wait till someone asks you to review it. If you see something that's wrong with the plan at any point in time, you put your own time. You know, we have them out there. I'm going to ask for your concurrence at some point in time during the year. Take some time to review those plans. Take a look at them. How do they line up with your internal policies and procedures? Because if I were to look at 19 hospitals, maybe 35 EMS agencies, and local fire departments, countless numbers of those, I myself, nor Lee, Greg, or anyone can make everyone kind of look at those things at one given time. You know, it's just not gonna happen. And not to include the other health departments and emergency management agencies that are part of us. So we got 11 of those as well. So, all right. Any other questions, concerns? Okay. Upcoming events, again, at Decon Training this Friday, the 3rd at Jersey Community Hospital. There is a course that I think I sent that out yesterday, day before yesterday, to the region. The folks down in Region 5 are having trouble filling this course, this BDLS, ADLS course. On the 6th and 7th. So if you got a copy of that and saw it, and you know some folks that can use that training or education, please sign up. It is free. The radiation burn surge exercise, June 22nd, that's online from 1 to 3, 11 to 1500. So please make sure you sign up to become part of that as well. I think that would be highly informative and give us some things to look back at, and at least, you know, help us redefine what we have in the current plans. You will see all of those plans today in the link today when we send them out. The IAM and National Healthcare Preparedness Conference are still going on. So those are the dates for those. You should be able to get signed up. I don't think the hotels are open yet. Maybe they are. But you definitely can see them out there in their web pages. They have them. And again, IDPH Summit is canceled, and maybe we'll get one next year, COVID pending, I'm sure. All right. Well, we are at about 1:34. I'll give one final for any alibis, questions, concerns. Okay, hearing none, I'd like to thank everybody for attending this quarterly meeting, and we will see you guys next month. Take care.